All right, everybody. Here we are learning about breast pathology. These are the core conditions, the absolutely basic stuff that you need to know in breast pathology. These are the conditions that are in the curriculum map. Now, I know that previously you have learned a lot about breast pathology. So these are slides from your previous breast pathology lectures. We're just going to briefly review them, and then we're going to move on to new stuff. Previously, you've learned about the normal structure of breast, how it is arranged in acini, and each of the little acini are lined by two layers of cells, an inner epithelial cell and an outer myoepithelial cell. You've learned about some common conditions such as fibroadenoma, the most common benign tumor of the female breast occurring in young women. It feels like a freely mobile ovoid mass that can increase in size. Mammography reflects its distinct outer borders, and the key words that we use when describing it are compressed duct-like spaces in a fibrous stroma. You have learned a lot about breast cancer. You've learned about the risk factors for breast cancer, which can basically be described as estrogen, genes, and other. So conditions that lead to increased estrogen exposure will increase the risk of breast cancer, including early menarche, late menopause, exogenous estrogens, including the estrogens that are given in the postmenopausal setting. Family history, of course, people who actually have the BRCA genes, and also people who have a cluster of lower risk genes, which together increase the risk in families. And then other radiation exposure. Yes, having breast screening does actually increase very, very, very tiny amount the risk of breast cancer. And then alcohol, obesity, and ethnicity. You've learned quite a lot about hereditary breast cancer, as well as BRCA1 and 2. There's P53 and CHEK2. You've learned about the normal functions of BRCA1 and 2. They're involved in DNA repair, particularly when you get double-stranded breaks. And they are normally an anti-oncogene that mends DNA, but when they're mutated, DNA mending doesn't occur, and there are more mutations. Okay, so you learned about the classification of breast cancer, in particular, the really important idea that there is in situ breast cancer that is confined to the ducts and isn't invasive, and then there's invasive cancer. You've learned that there are different types of invasive cancer, the most common being invasive ductal carcinoma, also called invasive carcinoma of no special type. But then there's others like lobular and medullary carcinoma, and we will cover a few more of those in the homework. You've learned that estrogen and progesterone receptors are important in breast cancer because they improve the because they mean that the breast cancer can be treated with hormones. And you've learned that HER2 is important because it is present in high-risk breast cancer, but there is a specific targeted therapy for it called Herceptin. You've learned about variants of DCIS, how it has different grades, how it has different patterns, and how a variant of DCIS can cause Paget's disease of the breast, which looks a bit like breast eczema, but on biopsy shows cancer cells within the epidermis. You've previously learned about the gross and microscopic appearance of breast cancer. so it appears as a stellate lesion, hard, often like scoria in the breast. And the microscopic picture of breast cancer of ductal type is that of a typical adenocarcinoma with infiltrating ducts lined by pleomorphic mitotically active cells. You have previously learned that breast cancer can be graded, that there is a grading system, and cancers that are grade 3 do much worse than cancers who are grade 1. And you've learned that breast cancer spreads particularly to the lymph nodes in the axilla, but also to the skin and chest wall and through metastases around the body via the blood. You've also learned that breast cancer can present after many years, recur after many years, up to 20 years after a person has had it. You've learned about important prognostic factors in breast cancer, including staging factors like tumor size, lymph node metastases, and distant metastases. You've learned about estrogen and progesterone receptor as prognostic factors and HER2. And you've learned that there are other tests that we can use for prognosis, such as Oncotype DX. And you've learned that moving into the new molecular era of cancer, that we can classify breast cancer according to its molecular type. Okay, so this is previous knowledge, so we're going to now move on from there. All right, so we have learned quite a lot about this, the knowledge of breast cancer. Some important things that you haven't really covered are fibrocystic change, LCIS, and then we will move on to the application of this knowledge. So what is fibrocystic change? This is a physiologic change in the breast that occurs in women between 20 and 40 years of age. It is due to estrogen, in particular, an overreaction to estrogen. In other words, the estrogen receptors are very sensitive, or there is a high level of estrogen. Fibrocystic change by itself doesn't increase the risk of cancer unless there is a very florid epithelial reaction as part of it. So what is fibrocystic change? So fibrocystic change gives women lumpy, uncomfortable breasts, but there usually isn't a defined mass. It can cause cysts to appear, which can increase in size in the second half of the menstrual cycle. And some women will have investigations for their symptoms, and it will show fibrocystic change. So what does fibrocystic change comprise in the breast pathologically? It's a combination of several estrogen-driven changes. The first is cysts. It's in the name, cysts. Okay, so we get cysts in the breast. Here is a fairly normal-looking breast acinus, and here is a cyst. The secretions build up inside it and dilate this duct space. It can undergo calcification, which can mimic the calcification that is looked for in mammograms with DCIS. Fibro is the other part of the name. Of course, there is increased fibrosis, which we can see around these dilated cysts. The third change we can get is apocrine metaplasia. So this is apocrine metaplasia here. Remember, the breasts are embryologically modified apocrine secretory ducts. And so what can happen is the normal breast acinar epithelium and ductal epithelium can change to the kind of epithelium that lines apocrine sweat ducts. And this happens in fibrocystic change. Carrying on, the fourth change is epithelial hyperplasia. So epithelial hyperplasia means that the ducts, which are normally lined by just 2 cell layers, have increased cells in them. Too many cells. These are not precancerous cells. There are just too many of them. Often it's quite like jumbled looking. Myoepithelial cells are still present around the outside, so we know this isn't a clonal proliferation, and there's no cytological atypia. The only risk is when this becomes absolutely florid, and then the risk of breast cancer does increase, but not as much as if there was DCIS present. Let's move on to lobular proliferations. So, like ductal carcinoma, lobular carcinoma has an in situ phase. Looks like these little baskets of eggs. LCIS is difficult to find on mammograms because it doesn't usually calcify or form a mass. So people can have LCIS in both breasts without noticing, and it is more frequently bilateral than it is unilateral. The problem is that it can go on and form invasive lobular carcinoma. What does it look like? Baskets of eggs. They're typically described as discohesive, which means they don't like join hands and form form solid masses like DCIS or form glands when they invade. That's because they have a mutation in E-cadherin. This is the same gene that is lost in signet ring cell familial cancer in the gastric mucosa. And so they just don't stick together. Cadherin genes are a bit like the Velcro between cells, so they're very discohesive. So here we have LCIS, and here we have invasive lobular carcinoma. So typically described as moving in single file between the collagen strands in the breast. You can see them here. People used to call them Indian files, but I'm going to tell you they aren't called Indian files anymore. We just call them single file. Oh, there we go. So now we've covered all the bases of knowledge, including your ELM work. So what we want to do now is understand how the information in the breast pathology report, which you will get to read, is going to determine therapy and prognosis. I write breast pathology reports every day. They are a long series of formulated information. But fundamentally, what they contain is the diagnosis, information that helps with prognosis, information that helps plan treatment, and also really basically it's how it's going to behave and the best treatment options. As well as things that we've discussed about prognosis, like estrogen and progesterone receptors, one of the really, really important things that we talk about a lot in breast cancer reporting is margins, because often women undergo breast conserving therapy, surgery, and so the margins, we spend an inordinate time being really precise about how far the breast cancer is from the margins and whether it's cut out. Let's consider this 66-year-old woman who has a lump in her right breast and a palpable mass adjacent to the nipple in the upper outer quadrant of the breast. She has an ultrasound as part of her investigation, which shows this irregular hypoechoic mass, which is 13 millimeters in maximum diameter and approximately at 12 o'clock. We're really concerned about this because it has irregular margins. It's taller than it is wide. It is hypoechoic and has the typical features on ultrasound of a breast cancer. Age is really important in forming the differential diagnosis for breast cancer because breast cancer is very much associated with age. People in their 20s, particularly if they have hereditary problems, can get breast cancer. but it's much more likely that young people who have a breast lump will have a benign breast lump. Nevertheless, if it is concerning, it needs investigating. So as part of the triple examination, the patient will be examined by an experienced surgeon. They will have mammography or ultrasound, and they will have a biopsy or FNA. So this lady is likely to have an ultrasound and an ultrasound guided biopsy. And this is the first step in the pathology. So let's think about this typical core biopsy report. What does each part of the core biopsy report mean in determining treatment? Right, so usually we start by saying what tissue is present. So it's breast tissue in which there is an infiltrating ductal carcinoma. Okay, so we know now that she has breast cancer, and usually our reports begin with the diagnosis. We then say what grade it is. So this is a feature that affects both the prognosis and treatment. And the grade is based on three things. It's based on the presence of tubules, nuclear pleomorphism, and the number of mitoses. So her breast biopsy shows that she isn't forming tubules very well. Less than 10% of her tumor is made of tubules. And so she scores a 3 for that out of 3. She's got moderate pleomorphism, and so she scores a 2. And she has uncommon mitoses. So this is only 2 mitoses in 10 high-power fields. So we add all those together. It's a score of 6. If the patient has a score of 3, 4, or 5, we call it grade 1. If it's a score of 6 or 7, it's grade 2. And if it's a score of 8 or 9, it's a grade 3. Each of these is scored out of 3, with 1 being good and 3 being more aggressive. DCIS is also present, okay? And this has intermediate grade nuclei. In other words, grade 2 nuclei matching the cancer, implying that the cancer has arisen from this DCIS. There is no spread into the lymphatics or capillaries or any other small vessels in the sections examined. This means that we can't see it. It doesn't mean that it won't be present on a bigger biopsy. Importantly, we always do the hormone status on this initial breast biopsy, because this allows planning of treatment and prognosis. So about 80% of cancers will be ER positive. It's a nuclear stain. So we stain the nuclei with antibodies towards the estrogen receptor, and we can see that these cells are positive, and this means that this cancer is very likely to respond to manipulation of the estrogen environment, such as either estrogen receptor blockers like tamoxifen, or reducing the amount of estrogen production like with aromatase inhibitors. This is the HER2. About 15% of cancers are HER2. They grow very aggressively, but that aggressive growth can be blocked with the use of Herceptin. And so the HER2 receptor, the human epidermal growth factor receptor type 2, is present on the surface of cells. And this is a HER2 immunohistochemistry, which is showing the receptors are positive. BRCA1 is particularly associated with cancers that are ER, PR, and HER2 negative. Let's think a bit more about breast cancer grading. Okay, so breast cancer grading is based on 3 observations, as I've just said: tubule formation, mitotic count, and nuclear pleomorphism. And so we have a score for each of those, 1, 2, or 3, with 3 being the least favorable score. So more tubules is better than less tubules. Less mitoses are better than more mitoses. And If the cell looks nearly normal, it's worse than the cell looking really horrible with pleomorphism. I do not want you, please do not memorize this table. The idea is a concept here that a higher grade breast cancer will behave in a more aggressive way, and that there are three components that make up whether we decide a breast tumor is going to be more aggressive biologically. Okay, so what is the most powerful prognostic factor in breast cancer? The answer is staging. So if a cancer has spread to somewhere else, in other words, there's distant metastases in the T, the size of the tumor, N, lymph node involvement, M, thing. If there's distant metastases, this is the most adverse prognostic factor. The next adverse prognostic factor is whether or not there are lymph node positives. And then the next most adverse prognostic factor is the size of the tumor. So staging is the most important thing in prognosis, as we can see here. So if breast cancer increases in stage, survival rate decreases. The next and most important one after stage is grade. So one of the main things that we do is stage and grade breast cancer as pathologists. Okay, so she then goes on to have a wide local excision and excision of 3 sentinel lymph nodes. So what does this mean? So a wide local excision means that the local area of the tumor and surrounding tissue is excised rather than the whole breast. Excision of 3 sentinel lymph nodes. What is a sentinel lymph node? During the operation, the tumor or the nipple is injected with a blue radioactive dye, and they use a gamma counter to work out where the tumor and nipple are draining to. And then they just take those lymph nodes out and send them to us. They do this rather than take the surgeon does this rather than take the whole axilla, because it avoids the problems of lymphedema in the arm. And also, if there is no cancer in those lymph nodes, means that they don't need any further axillary treatment. So here we go. So what we see is that she has a tumor that is 14 millimeters in greatest diameter. That, yes, we still think it's grade 2, and we think all margins are clear by 10 millimeters. We can't see any lymphatic or vascular invasion, and we do the sentinel node protocol, and that reveals no tumor. Okay, so we know this is a fairly small tumor, T equals 1C, and N equals 0 in the TNM system. Let's look at the questions. Is a 10 millimeter margin acceptable? Yes, it is. So this patient will go on to have radiotherapy, but doesn't need any further tissue excising. What is the sentinel node protocol? When people take out these sentinel nodes, what we're trying to do is find the tiniest bit of cancer in them. So we do lots of slices through them, and we stain them with immunohistochemistry, which helps us detect even the smallest number of breast cancer cells in them. So this is what this means. Immunohistochemical staining for cytokeratin revealed no tumor. Means that we have looked at these lymph nodes in great detail and can find no metastatic cancer. Okay, there are tools to help people predict whether or not they're at a person's risk of recurrence and death from cancer. So this is where you guys get active. You're going to pause the video and you are going to use two things. You are going to use a tool in order to see what this patient's prognosis is. So I want you to use your phone now and the QR code, and I want you to go to the predict tool. Just pause the video while you do that. So when you go to the predict tool, see if you can use the predict tool to determine these questions. What survival benefit does the hormone therapy give the patient? How long should it be given for? Should she have chemotherapy? Does it give any survival benefit? Now play around with the predict tool and see what happens if she becomes younger, HER2 positive, triple negative, has an increased tumor or lymph nodes positive. Try and see a pattern here, and what do you conclude about this tool and about treatment for breast cancer? This is just a thing that you can do to explore. Okay, once you have finished playing around with the predict tool, I'm going to tell you a story about some animals. So people sometimes, when they're in a whimsical way, talk about the barnyard of cancer. You can hear the original description by Gilbert Welch on this SoundCloud file. But this is an idea that says cancers have inherent different biological potential. You have a barnyard, and in it are three kinds of cancers: the turtle, the rabbit, and the dove. The turtle is a very, very slow cancer. It's like a grade 1 infiltrating ductal carcinoma in an 80-year-old in a low estrogen environment. This cancer is going to grow very, very slowly. This cancer will probably not be able to effectively escape the barnyard, the fence of the breast, and spread around the body. It's going to be very indolent. There's a cancer here that is a bird. This cancer is going to spread really, really early. It's going to fly out of its original site, a bit like small cell carcinoma of the lung. It's no good operating on the breast or the lung with a small cell carcinoma because this cancer has already flown. And the way we treat the cancer is with chemotherapy. Most breast cancers are like rabbits. Often we can find them in the barnyard and we can shoot them, get rid of them, remove them, and that cancer is cured. But if we're a bit slow at doing that, they will spread outside the barnyard and they will breed. So this is the idea that we tailor cancer treatment to the biological potential of cancers. The birds that fly away need lots of chemotherapy. The turtles can just be treated by local excision. The rabbits, like breast cancer, if they're small and early cancers, can be treated locally, but they do have the potential to spread and need chemotherapy. Next. All right. You will see some cancers being sent away for gene expression profiling. And the most popular one of this available in New Zealand is one called Oncotype DX, and it is not funded. It is funded in other countries, and maybe one day it will be funded in this country. What are these molecular tests? So we've been talking about the biological potential of tumors. We want to identify the tumors that are turtles versus rabbits versus birds, so we know which tumors need chemotherapy. Because if we're dealing with a turtle, we don't need to give chemotherapy. Whereas if we're dealing with a fairly active rabbit or a bird, we do. We can do this by looking at several things. The first is we can look at what we call traditional markers, like the stage and the grade and ER, PR, and HER2. We can look at it by looking at the mitotic rate and the replication rate of the tumor using a stain called P67. But we can also look at it by looking at the genes. And the aim of this is to try and distinguish really the turtle from the rabbit. So we want to find the cancers that do not need chemotherapy. So the aim of this test is to avoid people having chemotherapy. So what happens is we send away tumor to Australia, and they look at it with, they characterize 21 different genes and give a recurrence risk. And if the recurrence risk is high, then these women get chemotherapy, and if it's low, then they don't. Of course, many tumors, we know the recurrence risk is high already, so they don't need the test. It won't make any difference to whether they get chemotherapy. And we know that many tumors are low risk, they're turtles, we know that already. So it's used on this rabbit group of tumors, the medium risk group, to see which way it's actually going to behave, like slow turtle or bird. There are lots of other molecular tests available. And we try and do things that are effective, like immunohistochemistry, to replace things cheaply. But sometimes in this middle group, we do need a molecular test. Interestingly, these are commercial tests, so marketing plays a big part. And your parents are encouraged by these commercial companies to ask for tests. So one thing that is important for you is when you understand the pathology of breast cancer, you can help advise your patients about whether they need the test or not. Have a look at this advertising website. Tell me, well, don't tell me because I'm not here, but have a think about the messages that it's sending to the patients. Okay, so we've covered the core conditions in breast pathology. We've talked about interpreting breast cancer reports, and we have talked about the role that molecular tests play. What I'm going to do as a final thing is I'm going to run through some MCQs with you. So we talked about problem representations in the very first lecture that I gave you in this series. So the way to approach a problem representation, an MCQ, is to look for the problem representation. We have a 17-year-old woman, so already we know that she's unlikely to have cancer. Painless lump for 4 weeks. She has a slight family history of breast cancer, but not a large family history of breast cancer, and now has this 1 centimeter painless lump. So she's a young woman with a 1 centimeter painless lump in the upper outer quadrant of her right breast. What is the most appropriate initial investigation? I presume this is after it's been clinically examined. Because that is the most appropriate investigation, is a clinical examination first. And after that, what would you do? Triple investigation. Really, you've got to choose between radiology or biopsy. And next is the ultrasound scan. You would choose E. Why would you choose that? Well, mammography is really difficult on young women because they have lots of fibrous tissue on the breast and you get poor pictures. MRI, while it's used in people who have a very high family history of breast cancer, it isn't your first go. If you stick needles into breast lumps, you will distort them, particularly get hemorrhage. So it's always important to do the radiology before you do the biopsy. So you would investigate this woman with an ultrasound scan of the breast, which might look completely innocent. For example, probably fibroadenoma. And after that, you would go on to go, you would then go on to do a biopsy if needed. Okay, let's have a look at this one. So again, we have our problem representation, a young woman who has a description of a fibroadenoma, a smooth, mobile left breast mass. Ultrasound shows the typical appearance of a fibroadenoma with an ovoid mass, wider than taller, no calcification. All right, so here it's about recognizing the problem representation of a fibroadenoma. So we know that this is most likely to be a fibroadenoma. Let's have a look at this one. What is the problem representation? So this is a woman who's 35, firm irregular mass with an irregular 2 centimeter density with microcalcification. All right, so we're concerned here. So far, it's irregular and hard. Ultrasound has shown, mammography has shown calcifications. We're still concerned that it's cancer. So the next step is that she needs a biopsy, which reveals fat necrosis, which is reassuring. So this is teaching us that fat necrosis can also cause calcification. Okay, so what is the most likely cause for this breast lesion causing fat necrosis? And the most common cause of fat necrosis in the breast is trauma, seatbelt trauma, netball ball trauma, any other trauma causes fat necrosis, and that can clinically and by mammography raise concern of cancer. Okay, and then another MCQ. Here we have an older woman with a 4 centimeter, a large fixed hard lump in her right breast on self-examination. Now we know that this is a typical presentation of cancer. FNA shows the cells are consistent with cancer. In other words, pathology has confirmed cancer. Which of the following features of this carcinoma is suggesting a worse prognosis? So we know about prognosis in cancer now. We know that the worst prognosis is a problem with staging, right? So we know high stage leads to worse prognosis. So the worst thing she could have is distant metastases. And then the next thing she could have is axillary node metastases. And so here we have answer D, axillary node metastases. Another woman, she's younger now and has an ill-defined painless mass in her left breast. She has ultrasound and then a biopsy, which shows these things. And these are the key words for fibrocystic change. Okay, we've learned this: epithelial proliferation, apocrine metaplasia, fibrosis, and this thing called sclerosing adenosis, which is another benign duct proliferation that we see in fibrocystic change. Answer, fibrocystic change. Here we have a 39-year-old with an eczema area on the skin of her breast areola. We know that Paget's disease of the breast, we've learned earlier in this lesson, often presents like eczema. Okay, so we have a biopsy which shows large cells which are at the dermoepidermal junction and stain positively for mucin. So these are Paget cells. These are going to be cytokeratin positive if we did a cytokeratin stain, and they're adenocarcinoma in situ, so they produce mucin. So the answer, this is a very typical problem representation for Paget's disease of the breast. And then we have a 61-year-old woman who has pleural effusions containing malignant cells forming long rows, and also an abnormal area in her left breast. So we know that tumors in the breast that form long rows are likely to be lobular carcinomas. And so here we have the lobular carcinoma in the answers. Please do your homework. In your homework, you will learn about other different kinds of breast cancer and also be able to apply the clinical reasoning that I have demonstrated in these MCQs. This homework is aimed at helping you to recall in a couple of weeks all the stuff that you've learned today. Remember that we're doing active recall and spaced learning, and the homework is helping with that. Thank you.